Good evening, everyone. Happy spring. Welcome to our second research club of 2023, hosted by the Brain Health Center of the Rockies. My name is Kathy Kiefer. I'm the co-founder, along with Dr. Augusto Miravalle, as well as the president of this nonprofit organization. The intent of Research Club is to bring the latest developments of recent academic journals and have them explained in a way anyone can understand by a panel of experts in the field. Research Club is a free program to participants and is held 4 times throughout the year. During the second half of 2023, our last 2 research clubs will be on September 11th, where we talk about monoclonal antibodies in neurology, and November 6th, where we will look at neuromodulation and brain health. Tonight, we will engage in an exciting conversation regarding new therapies in migraines and multiple sclerosis. Our 2 guest speakers are Dr. Kristen Kutz and Dr. Anthony DeClusen. They will be discussing a new class of medications for migraines, CGRP blockers, as well as new class of MS therapies, BTK inhibitors. While BTKIs are not FDA approved yet, research is showing promising results in their ability to stop chronic inflammation in multiple sclerosis. As to our 2 speakers for tonight, Dr. Kristen Kutz is the Director of Research and Neurology PA at Comprehensive Neurosciences in Colorado Springs. She has been a member of Colorado Springs Neurological Association since 2000. She has a bachelor's in biology from Lehigh University in Pennsylvania, a master's in physician assistant studies from DeSalle University in Pennsylvania, and a doctor of health science and PhD from Nova Southeastern University in Fort Lauderdale, Florida. Our other speaker, Dr. Anthony DeClusen, received his undergraduate degree from UC Santa Barbara. He attended medical school at the Medical College of Wisconsin. Dr. DeClusen has spent the last 5 years doing his neurology residency and fellowship at the University of Colorado, where he has received additional subspecialty training in multiple sclerosis and neuroimmunology. Beginning in July, he will be starting his career with UC Health in Longmont, where he will be focusing on taking care of patients with multiple sclerosis and other neurological conditions. Our 2 moderators and co-chairs for Research Club are Dr. Brett Fling and Dr. Miravalle. Today's event is being recorded and will be made available within the upcoming days on our website, www.brainhealthcr.org. We would welcome you to use the Q&A box at the bottom of your screen to ask any questions you may have, and we will be sure to allow time for Dr. Kutz and Dr. DeClusen to answer as many of those possible within the 1-hour time frame. Before I turn things over, I would like to mention our sponsors for tonight's Research Club, which include EMD Serono and Bristol Myers Squibb. You can visit these companies and their products through our virtual exhibit hall on our website. At this time, Dr. Fling and Dr. Miravalle, it's all yours.
Thanks very much, Kathy. I think I'll start if that's okay with Dr. Miravalle. And I thought maybe we'd start with Dr. Kutz and get a conversation going about, I'm sure, as Kathy mentioned, I'm sure we're all very familiar with CGRP. We're going to find out what that means and have Dr. Kutz explain it to me. I thought maybe I'd start by complaining that Dr. Kutz got to do her PhD in Fort Lauderdale. I was in Michigan. It was freezing. Fort Lauderdale sounds substantially more enjoyable to do some study in. So Dr. Kutz, in all seriousness, to get us started, I was really surprised as we were kind of preparing this and working our way through some talking points and some questions that Migraine is the second largest cause of years lost to disability globally among all diseases. And there's a prevalence around the world of approximately 1 billion or more. And despite this really large burden of migraine worldwide, there's very few classes of therapeutics that are developed to combat migraine. After, I guess, decades, 30 years or so of translational research, this calcitonin gene-related peptide, CGRP, inhibitors have emerged as a promising tool in the prevention for migraines. And so before we maybe do a little bit of a deeper dive on these CGRPs and their relevance and their role in treating migraine, could you maybe just, from a very broad standpoint, remind us of the definitions and classifications of migraines to get us started?
Sure. And I will also say Fort Lauderdale was pretty awesome to go to grad school.
I knew it.
As far as migraine classification, I typically break it down into episodic and chronic. So episodic migraine is 14 or less migraine days per month. And then chronic migraines are 15 or more headache days per month. As far as, what the signs and symptoms or what the presentation, maybe it can really vary from person to person. Migraines can affect children, adolescents, adults, much more commonly affects women than men. Migraine can go through 4 stages, which would include prodrome, aura, the actual migraine attack, and postdrome. And not every patient is going to experience all 4 stages. It may just be 1 or 2. As far as prodrome, this typically occurs 1 to 2 days before a migraine. You might notice some subtle changes. Sometimes it's changes in mood. Sometimes it's hunger, food cravings, neck stiffness, feeling really tired. Yawning is another prodromal symptom. Auras are the next step, and that typically occurs within 60 minutes of the onset of pain. And the most common migraine aura is usually visual, where you might see bright flashing lights, sparkles, anything flashing lights, may have vision loss. Sometimes it could be sensory changes like numbness or tingling, could be weakness or numbness on one side of the body, where sometimes patients are really concerned that they may be having a stroke. Same with difficulty speaking. So these can all be kind of leading up to the migraine itself. As far as the migraine attack, untreated, it can last anywhere from like 4 hours to 72 hours. Pretty typical symptoms are unilateral pain, affecting one side of the head, sensitivity to light and sound, nausea, vomiting. Typically pain is like throbbing or pulsating, and it affects your inability to kind of do your everyday tasks. And then lastly, the postdrome is kind of the letdown after the migraine attack, where you might feel drained and, really fatigued for several days after the migraine attack itself.
That was excellent. Thank you, Christine. And so there's a reason why we put together these 2 topics, not only because it's an exciting era in neurology and neurotherapeutics, but also people with migraines and MS, they share a lot of similarities, right? So for the first, one of those is gender, right? They both have a gender, predilection for females. They both could present with focal symptoms, and some of those symptoms are similar between the 2. MRI features sometimes resemble, right? Those lesions could be mistaken for migraine lesions, sometimes for MS lesions. And often both groups of patients end up in ER with similar reasons. What makes it even more confusing is sometimes patients with migraines don't have headaches. So in your experience, Dr. Kutz, have you seen patients with migraines presenting with all of these constellation of symptoms without headaches?
Yeah, I think of it more as the ocular migraine. I don't know if you would agree, but ocular migraines, predominantly visual symptoms in the absence of head pain. I don't know, can you think of any other headache syndromes that I'm missing?
No, you're right. I mean, I think that's perhaps the most common one. Sometimes patients come with these basilar type of syndromes with vertigo and dizziness that sometimes is mistaken for a stroke, as you say, right? So I think that's that's one of the areas that we always try to educate our patients. When in doubt, of course, talk to your doctor or go to ER if that feels like something is an emergency. But yeah, I always keep migraines in the back of my head when I can't explain these focal symptoms, because sometimes patients present with these atypical features. So let's now dive a little bit deeper into CGRPs. And can you explain to us what is that?
So CGRP stands for calcitonin gene-related peptide. CGRP is a neuropeptide. It's a small protein, highly prevalent in the sensory nerves that supply the head and the neck. It's released at the onset of migraine, which tends to lead to that whole cascade of events that occur. CGRP inhibitors are a new class of medication that's been FDA approved, the first one maybe like 5 years-ish, and they can help inhibit the release of CGRP. And initially they were FDA approved to help prevent migraine. Now there are CGRP inhibitors that are used for acute pain at the onset of migraine.
I'll echo Kathy's sentiments at the beginning and encourage folks as we're going along. You don't have to hold your questions till the end, like is often the case when someone's giving a talk. So feel free to pop questions into the Q&A box, and we'll relay them on to Dr. Kutz and to Klusen as we're making our ways through. We do have a few in there already, Dr. Kutz, so I might just ask, and this is something Dr. Miravalli touched on already, but do we have a feeling for why these migraines are more prevalent in women than men? Are there hormonal interactions? What do we think underlies these differences in prevalence?
My first instinct would to think that there's a hormonal component. There also seems to be somewhat of a genetic component too, where usually there's family members, siblings, offspring, who also have migraine.
Okay, yeah, I mean, that's certainly the first thing that springs to mind. I'll ask one more that we have in there as well. So you mentioned that the CGRP is sort of readily found within sensory neurons that supply the head and the neck. Is that right? And are these in the periphery in sensory neurons, or are they more centrally located? Where do we find the CGRP localization?
CGRP is all over the body. I mean, for migraines specifically, it's more in the central nervous system, like near the meninges, not necessarily activated inside the brain. But yeah, I mean, the gut is another common area where CGRP is prevalent. The endocrine system is another one. Immune system, in the skin, bone, cardiovascular. Yeah, it really can be anywhere in the body, but for CGRP inhibition of migraine, it's targeted in the CNS.
Yeah, so I think this sort of raises a pretty obvious question that I bet several folks have then, right? If CGRP is so systemic and we find it with all these different systems and with these different areas, it must subserve a wide variety of functions. So are there, like we often see with certain pharmacology applications, are there negative side effects or consequences to inhibiting CGRP activity throughout the body?
Yeah, I mean, I would say overall in my clinical experience, the CGRP inhibitors are very well tolerated. At our research clinic, we did do several of the pivotal phase 3 clinical trials for the CGRP inhibitors and monoclonal antibodies. And overall, we're very well tolerated. I would say one of the more common side effects is constipation, and that could affect, depending on which medication, 3 to 6% of the population. For the CGRP inhibitors that are given via injection, sometimes you could see, injection site reactions where there could be some redness or pain at the site of the injection. Some of the CGRP inhibitors, you might see a little spike in blood pressure, but I would say overall, very well tolerated. And just would want to note that none of these medications are recommended during pregnancy.
So, and let's talk now about the benefits, right? So you mentioned that CGRP is widely distributed, perhaps in the CNS, in the meninges. And there are different ways that we can block that, right? So there are monoclonal antibodies, there are small molecules, the GPANs. So what has been your experience in terms of benefits? What type of response patients can anticipate?
So just to kind of review the CGRP inhibitor classes, I mean, it's really exploded over the past several years. So the monoclonal antibodies are large molecules that either bind to the CGRP receptor or CGRP ligand, and they do not cross the blood-brain barrier. They are currently approved for migraine prevention to reduce the frequency and severity of headaches. The first one, and I don't know, am I allowed to use medication names? Can I use actual names?
Absolutely, whatever is easier.
Okay. So the first one that was FDA approved was Aimovig. It's a subcutaneous injection every 28 days, comes in 2 different doses. That's the only monoclonal antibody that binds to the CGRP receptor. Ajovy and Emgality are 2 other injectable CGRP inhibitors that are monoclonal antibodies. They're also injected every 28 days. They both bind to the CGRP ligand, so a little bit different target. Vyepti is a CGRP inhibitor that also binds to the CGRP ligand. That is infused every 3 months or every 90 days. And there's 2 different doses for that medication, 100 milligrams and 300. So that kind of rounds out the monoclonal antibodies. As far as the GPANs, which is a class of medication, they are CGRP inhibitors, but they are small molecules. They cross the blood-brain barrier and tend to work a little bit quicker. The GPANs, as I mentioned, do cross the blood-brain barrier, and they bind to this CGRP receptor. So the first 2 that were FDA approved were used for the abortive or acute treatment of migraine. That was Ubrelvy and Nurtec. And since that time, Nurtec also now has an indication for both acute and prevention. So if it's taken routinely every other day, that's considered to be the preventive regimen. Qulipta is also a daily CGRP inhibitor, small molecule GPANT that comes in 10 milligrams, 30 milligrams, 60 milligrams, also binding to the CGRP receptor. And then lastly, I'm not sure if it's even commercially available yet, but Zavegepant is a nasal spray abortive. So I think that will be available in pharmacies soon. And that will also be considered to be an acute migraine medicine. But that kind of rounds out the 2 classes of CGRP inhibitors, the monoclonal antibodies, as well as the GPAN class.
Well, that's a lot. So let me see if I got it
know.
right. So you have on one side the preventives, right? So those are the ones that we use to prevent headaches from happening. And you have the injectable ones, the subcutaneous, which are the monoclonal antibodies. And people can use 1 injection every month to prevent the headaches from happening. And on top of that, you have the oral options or sublingual in the case of Nurtec, which can you mix them? Can you use the injectables and on top of that, prescribe, for example, the abortive as well?
So I do. I mean, I've been doing that for a long time. I'm not sure if there's a lot of data using them concomitantly, but I would say in clinical practice, as far as what I do and the colleagues that I work with at CSNA, we all have used the monoclonal antibodies as well as the GPANs in combination with each other.
That's excellent. And so in terms of efficacy, what's been your experience? How effective these medications are compared to, let's say, the old school form of treatments, which was the antidepressants and the antiepileptics and the beta blockers? What has been your experience so far?
Yeah, I feel like in the past, because I've been a neurology PA for 23 years. So most of the medications that we use to help prevent migraines in the past were recycled from something else, whether they were like originally seizure medications or antidepressants or blood pressure medications, where just kind of incidentally, seems to be helping with headaches somewhat. But what's different about the CGRP inhibitors is they were developed and targeted specifically for migraine. And I hate to use the word game changer, but I think many of our patients would really say that this has really changed, the course of their migraine treatments over the years.
I think you can tell a lot about our moderators based on the types of questions we ask. Dr. Miraval is a glass half full guy. He asks what the benefits are and how well they work, and I ask what the negative side effects are. Dr. Kutz, we do have some questions coming in from our attendees as well, so I might ask one of those and send it your way. So one of our participants says that both of her sisters experience hemiplegic migraines, but she doesn't have this type. She's currently on Emgality with some success. She tends to have these migraines for weeks at a time when they come on. And the only time she's been without a migraine for a long period of time was after the monoclonal antibodies given following a COVID diagnosis. She's tried Nurtec and Amavig with negative consequences. So do we have any thoughts, or could you talk to us about the, if I pronounce it wrong, I apologize, Cephali devices? Cephali devices.
Yeah, so we have some patients that use Cephali. It's kind of like a device that you can put on your forehead. I don't know if I'm going to describe it correctly, but it's somewhat of like a TENS unit kind of effect. And they use it typically in combination with their prescribed medications. I think the downside is it's not covered by insurances, or at least hasn't been in the past, where it's had to, be a cash pay option for patients. But, otherwise, I don't think that there's very much risk associated with using the Cephali device.
So you touched on the idea of, or comparing to something like a TENS device. And this is actually one of the things that I was really thinking of when you were describing migraines to us up front, and the types of, symptoms that tend to sort of be in that prodromal phase before as it's coming on. And you described a wide variety of sensory symptoms, right? Whether it's that sort of blurred vision or occluded vision, or starting to feel numbness and tingling in the limbs and the extremities. So if all of these sort of sensory feedback systems start to identify and tell you when that migraine is coming on, has there been any work on trying to do things like sensory alteration, stimulation, changing the threshold of sensory feedback through something like a TENS unit?
I think some of our patients have had success with biofeedback too. I think that's pretty widely used, or has been in the past. But like I said, it's usually, like a multidisciplinary approach where, you try, see what works. So many of these complementary treatments can really be effective, with the prescribed medications too.
Excellent. Well, I think that's kind of concludes the migraine discussion, right? I think we have kind of reached the point in which I'm convinced that CGRP plays a critical role in the pathophysiology of migraines. And, every time we discover something like that, the tendency is like, okay, if CGRP is there, let's block it and let's see what we get. And it's nice to see that from a mechanistic standpoint, blocking a peptide that is clearly involved in the pathophysiology of migraines leads to good clinical results, right? And that's been consistently seen with the monoclonal antibodies, which is perhaps the most targeted way to block that, with the small molecules, the GPANs, that actually prevent the release of the CGRP into the synaptic cleft. So you have all these different ways to block that. And there is a consistent improvement, or at least prevention, in both migraines as well as abortive therapy. So I think, you just did a good job in convincing me that that's kind of like a breakthrough in the management of migraines. And if I understood correctly, there is minimal, if any, risk, right? So you mentioned GI symptoms, perhaps nausea, constipation, but those are usually things that we can help patients tolerate, and if not, then move on to the next strategy. Is that a fair assessment?
I think so.
All right. I didn't mean to put words in your mouth, but I always like to summarize whatever was discussed. And with that, Dr. Flynn, how do you feel about moving to the next part of the talk today?
Yeah, I think that sounds great. I actually like Dr. Kutz sort of gave us, I think, a very nice transition into this idea of, oftentimes the approach to treating the migraines may end up being combinatory and requiring multiple different avenues, and oftentimes putting those pieces together makes a big difference. And that not the same treatment works for everyone, which we're going to swap over into discussing some new components in multiple sclerosis. And I think for a lot of our attendees who have been in the research club for the last few years, or have been a part of our MS Brain Health and Wellness program as well, are well aware that right, MS often requires a combinatory approach, and what works well for one person doesn't particularly work well for another. So if we swap over to MS, for those of us who are maybe a little less familiar with it, again, it's a very common autoimmune mediated disease affecting somewhere in the ballpark of 1 million people in the US and about 4 million worldwide. So not quite at the billion worldwide level as we are with migraine headaches. And the current therapies that are available for MS reduce both the number of relapses and relapse-associated worsening of disability. So that increased impairment in function that comes along with each relapse, which is assumed to be mainly associated with the infiltration of peripheral immune cells back into the central nervous system. However, there are therapies that are approved that are less effective at slowing disability accumulation in patients with MS, potentially in part due to their lack of relevant effects on the central nervous system compartmentalized inflammation, which has been proposed as one of the key mechanisms that might drive this disability and continued accumulation of disability in folks with MS. The term smoldering inflammation might be new to some of us, and it's been proposed to explain this chronic compartmentalized inflammation in MS. So if we swap over now maybe to Dr. Declusen, could you explain to us what this sort of novel phrase of smoldering inflammation is?
Yeah, so we think about MS in kind of two different phases, which have some overlap. And so the way I kind of break it down in my mind is what you were already kind of discussing, is that you have relapsing MS, or relapsing remitting MS being the other name, and then progressive MS, which seem to have two different maybe types of mechanisms that are going on to cause the inflammation. And so with relapsing MS, you have a very kind of rapid onset of acute inflammation that involves specific cell types that can cause a new scar essentially to form within the brain or the spinal cord. And then with smoldering inflammation that may play more of a role in progressive MS, you have this kind of just chronic inflammation that may be occurring within already developed MS lesions that can potentially persist over many years and can cause ultimately kind of neurologic decline years down the road after an initial attack from your MS, from that original lesion. And so our medications have been really good at targeting the pathophysiology that affects relapsing MS, but they just haven't unfortunately been as good as potentially targeting that chronic inflammation that may be going on in those older MS lesions.
Excellent. So, Dr. Declusen, when we reflect back to, what we've been doing with multiple sclerosis in the last 20, 30, 50 years, right? A lot of what we do is kind of informed from clinical research, clinical trials. And in order to enroll patients in clinical trials and being able to compare apples to apples, we often try to select patients that had a similar clinical phenotype, right? Meaning relapsing remitting MS patients and secondary progressive MS patients and primary progressive MS patients. And that is great from a kind of like research standpoint. However, in a sense, that created this artificial distinction that there are different types of MS and there are different phenotypes, right? And that actually stems back to, the early 40s and 50s, which we didn't have MRIs, and all we can do is, name what we see, right? And when patients have relapses, we call it relapsing remitting, right? And when patients start to progress, we call that secondary progressive, right? However, now we have tools, and now we have ways to actually look at the MS from different lenses, right? So what is your kind of view of, MS when you put together the clinical aspects, the MRI, now you're talking about smoldering MS.
Mhm.
Are we looking at that in a stepwise progression that, you first have acute inflammation and then once you go to secondary progressive MS, you start with smoldering? Or how do they play in the continuum of MS?
Yeah, I think that last word that you used there is a great kind of adjective to describe it. It's MS is more of a continuum. I think of it as being, one disease process. MS is MS is MS, and kind of these artificial distinctions that you had mentioned are just that. They are just something that we as clinicians or researchers kind of defined over the years, but it's all the same disease. And so often kind of the way that I think about MS kind of on this continuum is that it classically in most cases will start with relapsing, remitting type of pathophysiology predominantly. And as the disease progresses, that kind of declines over time in terms of the pathophysiology of the disease. And then there is some of that smoldering inflammation that is beginning even early on in the disease that we know of. And as the disease progresses over time, kind of the smoldering inflammation increases. So you almost have this kind of cross section maybe in the middle where they're maybe occurring evenly, but as you progress, that smoldering inflammation is maybe more responsible for the accumulation of disability is what we think. And so it's all one disease that just kind of has varying degrees of overlap in terms of the type of maybe inflammation that's occurring over time.
That's really interesting. So oftentimes we'll tell folks, clinically or from a research standpoint, when we're talking with individuals with MS or discussing it and trying to educate people on MS, that we say, there's some numbers of 70% of individuals with relapsing or remitting MS will transition or progress into that secondary progressive MS style. And so it sounds like from maybe how you're describing it, that when they progress, so to speak, or transition into that secondary progressive stage, that really they're just maybe shifting over into more of this smoldering inflammation as maybe the chronic symptom of what's or mechanism that's underlying at that point.
Yeah, I think it's just the ratio in terms of that chronic inflammation becomes higher. And so that may be what's driving that process more as people get into the later stages of the disease. I mean, thankfully, with the medications that we have now being as good as they are at controlling relapsing forms of MS, the hope is that if we can still diagnose it early and get them on a good treatment for controlling relapsing MS by decreasing the number of lesions that accumulate over time, they may never evolve into progressive MS from a clinical standpoint in terms of their symptoms. But for the people who maybe are caught later in their disease course, that smoldering kind of chronic inflammation is going to be a bigger driver of their disability down the road.
Yeah, I mean, this is one of the things we always are asked very often, and I'm sure someone will throw in the Q&A, right, is why do some folks quote unquote transition or develop more of this burden for the smoldering inflammation, and other folks maybe don't seem to how we've historically described it, transition into that secondary progressive MS. So it sounds like maybe your thoughts are that it could just by and large deal with how early they're caught in that relapsing and remitting phase, so to speak, and then how well the treatment takes place acutely.
Yeah, I think so. I mean, from what we know, people who are at higher risk of developing progressive disease are people with a higher number of brain lesions and a higher number of spinal cord lesions. And so if we can ultimately try our best to limit that number as much as possible, I think we're limiting their risk as much as we can of developing it down the road.
That's interesting. So, and we recently kind of like learned through the development of therapies that B cells play a critical role, right? And we, again, going back to our framework. We tend to just cluster things into buckets, and that could be wonderful to organize our thoughts. But the risk of that is oversimplifying a very complex disease process like MS, right? But what we've learned from that is that if you knock down B cells, that translates to an incredible amount of high efficacy in stopping the markers of acute inflammation, whether it's relapses or new lesions. However, even in those highly effective therapies, the so-called anti-B cell therapies, patients still continue to progress. Not all, but a proportion of patients continue to have progression. So could you speculate into kind of like what is the role of B cells in MS? And are we covering what is so-called the smoldering inflammation? Are we impacting that by knocking down B cells?
So MS, yeah, as you said, is a complex disease in that there are many different things that are probably contributing to the inflammation of MS kind of over its disease course. And the B cells are a type of immune cell that have been found to play probably a very big role in relapsing forms of MS. How they're doing that is not entirely clear. So the way I think of B cells as they're the part of your immune system that both create antibodies, which are responsible for, ideally, what they're designed to do, bind to various infections so that it can tell your immune system, hey, here's an infection, we should destroy it. But they are also going to be collecting proteins from outside and presenting them to other types of cells within the immune system to, again, kind of let the rest of the immune system know, hey, there's an invader, an intruder here, we need to get rid of this. And so for reasons that we don't understand, and to my knowledge, the B cells are acting in some way to contribute to kind of the inflammation associated with relapsing forms of MS. There's theories that have recently come out. There's been a lot of hype about Epstein-Barr virus, also known as EBV, the main virus that causes mononucleosis. When most of us are young, we contract it. The other name for it is called kissing disease. And it just causes usually just kind of a mild flu-like illness in most, but the virus is, once you're infected with it, is known to lay dormant within the body. And there have been there have been genes that have been shown to maybe be triggering the process that could be a major factor in the start of MS. It's not the only factor that we know of, but it may be a major driver behind MS. And EBV does infect B cells. And so that may kind of be how that process is ultimately started. As far as how B cells play a role in that chronic inflammation, it's also less clear. It doesn't, I mean, we can see in chronic smoldering inflammation in MS, there are B cell populations within the brain, usually on kind of the outer surface of the brain, that may be playing a role in that chronic inflammation, but there are also other cell types that are within the kind of areas of chronic inflammation. The main one that we're wondering could be playing a larger role in that chronic inflammation is a cell type called microglia, which is just an immune surveillance cell that exclusively lives in the brain and the spinal cord. And so we're wondering if we may be better in targeting this chronic inflammation by targeting not only B cells, but maybe other cell types, including microglia. And the issue with our current therapies is that while they do target B cells well, they don't really cross over into the brain very well because they're larger molecules, and smaller molecules are only capable of crossing into the brain, and so may not affect that kind of chronic compartmentalized inflammation that's going on in the brain. And they definitely aren't targeting microglia, at least kind of what's out on the market as it stands right now.
No, that's wonderful. And I'm going to try to dissect all the things that you said, because it was a very eloquent, complex answer. So if I understood correctly, so what we're dealing with here is a disease process where, you have acute inflammation. And that acute inflammation is driven by many cells, perhaps triggered by Epstein-Barr virus, which some will venture to say actually it is a necessary factor in the pathophysiology of MS, perhaps not the only one, but one that actually has the strongest predictive value in terms of developing MS in those who have certain genes and perhaps certain predisposition to develop autoimmunity when exposed to Epstein-Barr virus. You mentioned something about B cells playing a critical role in acute inflammation, right? In antigen presentation, in development of antibodies, right? But you also mentioned something that is new to this audience. We never talked about that before, which is microglial cells. And those are the cells in the CNS, in the central nervous system, that perhaps play a critical role, right? I mean, normally we see microglial cells as playing a beneficial role, right? Stopping inflammation. But what we're learning now is that in certain circumstances, they can change the behavior, right? And they can become inflammatory, right? And, in MS, you see this trend, right? That cells that normally should be playing a beneficial role, sometimes they're turning into a negative role, right? And what determines that is environment, perhaps genes, perhaps other factors. But I want you to expand a little bit more into something that you alluded to, which is the highly effective therapies, the anti-B cell therapies, don't cross the blood-brain barrier, don't get into the brain, right? So the effect that we get, the benefits, are peripherally. So if you can design an ideal therapy, what will be the elements of that therapy, based on what we know today, that you would like that therapy to have?
I mean, so in an ideal world, it would be a drug that targets all of the cells involved in the inflammation of MS, that easily crosses the blood-brain barrier so that it can actually target those cells in the areas where it's needed, and does not have any serious side effects that coincide with it. And so there is a new class of drugs that is currently undergoing trials for something called BTK inhibitors, which is short for Bruton's tyrosine kinase inhibitors. So Bruton's tyrosine kinase is a type of protein that lives inside certain cell types throughout the body. And it basically is involved in cellular activation and cellular signaling. And basically what was discovered, it was originally discovered in patients who had a mutation, who it was working inappropriately. And we found that, oh, this may be something that we can potentially target with a medication. And it was originally these class of medications designed to target this for people who have certain cancers that involve B cells, because this Bruton's tyrosine kinase are largely found within B cells. And so these cancer researchers found that in targeting those, they could very well treat these types of cancers. And we have since borrowed this medication or class of medications from the cancer world, and are now trying to adopt them for treatment of MS as well as other autoimmune diseases too. And so not only are they found within B cells, but they're also found in microglia. And so maybe can target that smoldering inflammation a little bit better than what we already have, and are also able to cross the blood-brain barrier so that they can affect the cells within the brain to hopefully calm down that smoldering inflammation is kind of the hope with these medications.
So if I understood this correctly, so BTK inhibitors have the potential to work in B cells, but also in microglial cells. And because of the small molecule component of that, it can easily cross the blood-brain barrier. So there is a potential to affecting not only peripheral inflammation, but also central compartmentalized inflammation. Is that correct?
That's a great summary, yes.
Okay, so I'm going to go back to a question that was posted by one of members of our audience, which has to do with anti-B cell therapies, monoclonal antibodies in the context of primary progressive MS. So we talked about, being very effective in acute inflammation, in relapsing remitting MS, and then we talked about these arbitrary distinctions. And now we know that there is also a benefit because there is a label approval for ocrelizumab in a primary progressive. So what can you tell us about the use of anti-B cell therapies in primary progressive multiple sclerosis?
So it seems like, based upon the data that we have, that ocrelizumab can be beneficial for progressive forms of MS when looking at it in a large population of people, is how I've interpreted it. So it's unfortunately not going to work the same in every person, is kind of the gist of that. And some people it may be more effective, and some people unfortunately less, and some people maybe not at all. It's probably unfortunately not going to be a game-changing treatment for anyone with progressive MS, because really it is going to be targeting more so that acute inflammation that occurs within relapsing remitting type of MS. But there may be a little bit of benefit in slowing the progression in those with progressive forms of MS. But unfortunately, it's just not going to be a game changer right now. And so that's why there's a real need in this kind of space to find a medication that will hopefully provide better benefit for patients who have progressive forms of MS.
And I apologize, Dr. Flynn, for taking over all the questions, but as you know, we are both passionate about this field, and I think it's an exciting time, right? So you mentioned about an unmet need, right? And I think we all agree in terms of addressing smolder inflammation or chronic inflammation in MS in an unmet need. So what can you tell us more about BTK inhibitors? What's your expectation in terms of what benefits can we anticipate from this intervention?
So there are currently 4 drugs that are undergoing trials right now, with I think another one potentially maybe going to start trials soon. There are 2, I guess there's 3 drugs right now that I know of that are undergoing trials for relapsing forms of MS, 2 drugs that are undergoing trials for progressive MS. And the 2 that did have phase 2 studies that were published in the last few years did have promising data with regards to relapsing MS, but none have kind of published data so far with progressive MS. And the 2 that published data for phase 2 trials for relapsing MS should have phase 3 data later this year, is the hope. The progressive MS trials hopefully will have data out there in the next, I think, 1 to 2 years, something like that. So we'll hopefully have some good information in the next few years about potentially how these drugs are working in both forms of MS and how they can mix kind of into what's already on the market. The unfortunate maybe side effect that's kind of coming out of these trials is that they may be toxic to the liver, not in a large population of patients, but we are seeing that as a potential side effect of these medications. And so something that we'll be keeping a close eye on once all of this information is published. But in an ideal world, the progressive MS studies show that they can be beneficial. And so we would have more tools in our toolbox to treat progressive MS.
And Dr. Declusin, just for clarification, how are these medications being administered?
So these are oral medications, most of them twice a day. There is one that is just a once a day medication. And so may be more of an appeal to people if they are proven to be at the very least equivalent to what we have on the market. They may be more appealing to some rather than infusions or injections if that's what people are currently on, just because some people might prefer an oral option.
I don't know why I'm a Debbie Downer today, but I feel obliged to ask Dr. Declusen, are there specific side effects or drawbacks to these BTK inhibitors that you were talking to about us a few minutes ago?
Yeah, so the main one, again, that we're potentially going to be looking into is that they could cause some liver irritation or liver toxicity is the main one. Otherwise, these are immune modulators, and so as a result, people are putting themselves at higher risk for infections. And what we're seeing from the data that's been published is that in general, they aren't serious infections. They're generally like common cold and things like that. But those are the two things that we're going to be looking for as these come out.
So we have a very challenging question from Shannon, which she's asking, well, if EBV is a potential trigger for MS, why don't you focus on targeting antiviral therapies as opposed to immune suppressive therapies?
So it's a great question. It's something that people who are a lot smarter than I are actively working on. I know there was an MS conference that I attended just a couple of months ago where this was a very hot topic of people discussing potentially antivirals, as well as if for people who've already contracted EBV, as well as potentially an EBV vaccine to prevent contracting EBV. And so these may be things we could see in the coming years, how they will impact MS care or treatment. It's probably several more years down the road, but at the very least, people are looking into this right now.
And we have another wonderful question from Jeff, which has to do with, the chicken and the egg, right? So instead of going after, immune cells, targeting that once they already have that abnormal behavior, right? Why waiting until that? Can we go to the root of the problem? Can we use mesenchymal stem cells and, in a sense, reprogram cells to not have that abnormal behavior? So can you kind of share your opinion on what is the status of stem cells in multiple sclerosis, particularly with mesenchymal stem cells?
Yeah, so I think about stem cell therapies in kind of two classes. So you have what's called an autologous stem cell transplant, where they are basically harvesting your own immune cells from your bone marrow, totally depleting and destroying your bone marrow and replacing your immune system with basically fresh new cells. And this has been tried in the treatment of MS with some success. And there is hopefully a larger trial that's undergoing right now that may provide us more data down the road. But the times that we consider using that treatments are pretty limited at this point, because while we have gotten better at performing this treatment, it is still comes with risk. And the worst of those being death from usually infection, because we're depleting your entire bone marrow. And so we really approach that treatment with a lot of caution and really only reserve it for those patients who have very aggressive forms of MS who are not responding to other therapies. And so that is the more kind of well-established type of stem cell therapy for MS. And then there is a separate type of stem cell therapy on the market called mesenchymal stem cell transplant, where they are either harvesting cells from certain tissues in your own body, either via bone marrow or fats, or sometimes from fetal tissue, and just either transplanting them by infusing them into your blood or your spinal fluid. And there's no kind of actual bone marrow ablation that occurs with those treatments. And so you are not necessarily replacing your immune system when you get a treatment like that. Right now, there's been no good data to suggest that any of those treatments are helpful. They're really only kind of in the experimental phase. And we don't necessarily think that they are, those cells are going in and kind of replacing any of the cells that are causing the inflammation. We think that they're more releasing kind of these chemicals that may be altering your immune system's behavior in some way. And you probably will see a number of different places that are advertising for these various treatments. And I would tell all my patients to proceed with those treatments with a lot of caution, because there hasn't been good data to support their use. And there can be unfortunate infectious complications that can occur, like we've seen in some of our patients here at this clinic. So nothing out there that I would strongly recommend at this point as far as stem cell transplants or treatments.
So I have one more question for you, Dr. Leclusina. It's more of a provocative question. So let's go back to BTK inhibitors. So if I understood this correctly, they have the potential to work on B cells, peripheral acute inflammation. They have the potential to work on microglial cells in the CNS, perhaps B cells in the CNS as well, targeting that more chronic smoldering inflammation. And going back to the initial statement, that we are understanding that now acute inflammation and smoldering inflammation perhaps occur from the beginning in someone with MS. We don't see the clinical consequences of smoldering inflammation perhaps later on, but we know that both processes occur simultaneously very early in the process. So if everything pans out to be true, that after the phase 3 trial data is released, we learn that BTK inhibitors have the potential to affect both acute and chronic inflammation. Why not using those earlier in the course of the disease?
That is a fantastic question. It certainly makes sense from a mechanistic standpoint. So we'll have to wait and see how this all shakes out.
Well, we have one more question, Kathy, if you don't mind me sneaking one in here under the bell. And Lisa asked, she says, this may be off topic, but I wonder if we could speak to movement interventions, things like exercise, dance, et cetera, and whether these things influence the efficacy of drugs. And, this is exactly the type of stuff that I study, Lisa, so this is never off topic. That's a perfect question. I think very much to Dr. Kutz's input earlier, discussing migraines and the potential for different combinatory approaches. I think the answer is absolutely yes. These components are very often improved by adding on physical components of movement, whatever those might be. I think one of the things that we've heard several times today, as we focused a little bit more on the progressive MS side of things, as opposed to the relapsing remitting, where so much work has been done traditionally, is that there really are these unmet needs for folks with the more severe or more progressive forms of MS. And I think one of the exciting things that's out there right now is that policymakers, clinicians, researchers, et cetera, all feel the same way. And so maybe I'll ask Kathy if she'd be willing to post. There's been a bit of a new white paper published recently from a group that is called the International Progressive MS Alliance, that is comprised of a variety of organizations that study MS at all levels. And they're very interested in pouring a substantial amount of money into multiple stage trials for the remainder of the 2020s here. So over the next 7 years or so, that is dedicated to improving well-being through proven therapeutic approaches, is what they call it. And so this work is specifically designed to fund research and clinical outcome measures for individuals, focusing on mobility, fatigue, pain, and cognitive function in individuals specifically with these more progressive MS forms, or the smoldering inflammation form, as we might start to think of it now, to try and take the combination of some of these therapeutic approaches coupled together with maybe a bit more of movement related approaches, if you will, exercise, gait rehabilitation, et cetera, to really try and drive these symbiotic and combinatory improvements in function across a wide range of domains. So I think it's a really exciting time to be diving into these more severe forms of progressive MS.
Excellent. Well, I think that concludes our discussion for this evening. Huge thank you, Dr. Kutz and Dr. DeClusen, for a wonderful overview and conversation regarding these new therapies for both migraines and multiple sclerosis. Of course, thank you to our moderators as well, Dr. Fling and Dr. Miravalle. Lastly, I would like to recognize our sponsors for tonight's research club, EMD Serono and Bristol Myers Squibb. And I would welcome everyone to continue to visit the website for future updates on research clubs. And on that note, I will say goodnight to everyone and hope you all have a good evening. Thanks so much.